Hello, can you hear me? Oh, okay, it's back now. Okay, so I think I'm having an issue with my sound today. So, what we want to do this week is to look at weight management strategies. And so, in the past 2 weeks, that is before and after reading week, before reading week, we talked about lipids, which was led by Samer from the nutritional sciences. He's a postdoc from nutritional sciences. And then we talked about proteins last week. That was led by Naomi O. What we want to move on to do this week is to, can you hear me okay? I feel like the sound is a bit muffled. Can you hear me? Okay. As long as you can hear me. No? I'm going to try to use the podium mic. It's not the best, but. Hello? It's not a good tech day. Okay, hopefully you can hear me now. Yeah, it's a bit better. Okay, so what we want to do today, or for today and tomorrow, is to look at weight management strategies, and then we'll move on to talk about regulation of food intake and why weight management strategies are often unsuccessful in the long term. In the past few weeks, we've looked at lipids, we've seen protein, under lipid metabolism, and carbohydrate. We looked at metabolic changes that can happen when one has increased body weight. So as a result of having excess adiposity, there are changes that happens to the metabolism of carbohydrates and lipids as well. Okay. And so we've seen how excess weight gain could increase the risk of type 2 diabetes. It could increase the risk of cardiovascular diseases and some types of cancers as well. Okay, so as I mentioned, we will be looking at, first of all, weight management strategies. We'll move on to talk about how food intake is regulated by the body and why sometimes weight management efforts are not sustainable. They are unsuccessful in the long term. And then finally, we will look at some weight-related issues throughout the life cycle. Okay. And so there are some documents, I will talk about the term test grades in a second. So there are some documents that have been shared, supporting documents. Hopefully you've seen them under this week's module. And also textbook readings that are related to it. One of the activities that we'll be looking at together in class is in the textbook as well, looking at adolescents and weight gain and weight loss, specifically in adolescents. Okay, now to the term test grades. So typically this will be when I show the stats for the term test grades, but the TAs are working on it. And so we're hoping that by the end of the week, it will be published as well. I have the concerns were reported to me where you had repeated questions, and so there were multiple announcements during the test, and I do appreciate that it does introduce some stress. And so the term test will be adjusted, the grades will be adjusted. I will let you know based on the stats that I get from the test, how that will be adjusted, and it will be announced on Kirkus. Yes, go ahead.
Will that also be true for those of us that wrote in accommodating testing sources and thus did not have the ability to hear those?
So those were essentially repetitions, which I believe you would have noticed. There were two questions that were repeated. Yes.
There were two questions that were repeated, but one of them had a slight difference from the question that came before. So
Right. In the answer options, maybe?
no, it was, so I distinctly remember this, I emailed you about it. There was one question where it was like about carbohydrates, And then there was a copy of the question where carbohydrates was sometimes replaced with fats.
So here's what we're doing with the grading. So typically the grading on the Scantrons is done by Remark, which is a software that we use to grade the Scantrons. And so we have programmed for it to ignore the repeated questions in the grading. And so that will be automatically done. If you have issues, we will announce a test review date after the results are released. And so you can come in and actually take your paper and take the question paper. You cannot take it away, but there will be a room reserved for that you can look at your answers and look at the answer key and compare to make sure your test was graded properly, if that's a concern, okay? So there will be time for that. And also, there is also a scheduled time for a regrade or additional feedback for assignment 1 as well, okay? Yes, go ahead.
Yeah, I was just gonna say, because apparently, like, I also wrote in accommodation.
Right.
So I didn't hear any announcements about the testing.
So I'm happy for you to come in, and apologies for all the back and forths with accommodated testing. What can be done, the best I can do is to have you come in for a review, and then I can answer all questions you have. So if you see that there's a discrepancy or you thought an answer was correct and it's not, I will be there to explain that to you as well, okay? So I think that, and this is open to everyone, not just those in, who had accommodations as well. Yes? Yes. No, you will not lose marks for the repeated questions. So as I said, the remark has been programmed. We did set up the answer key so that the answers you were asked to skip will not be graded. And so it will be out of a total of 38 instead of 40. Okay, so that shouldn't be a problem. But in the event that it's a problem, on the review date, we are happy to look at your Scantron again and fix that. Okay. So if you can, there will be, I think, 2 options, 2 different dates given for the review. I'm happy to also pull your Scantron out if you book an online office hour or an in-person office hour, and I'll take a look at your Scantron, and we can take a look at it together. Okay? I'm just not able to give it to you to take it away, but we can do it during the review session or during our office hours. Okay? All right. Was there any other question related to that? So in the first section of our discussion for today, we'll deal with the strategies for the prevention and treatment of obesity. In the second section, then we'll be looking at regulation of food intake, and we'll be able to explain some of the strategies for weight loss that are often unsuccessful. And then finally, in section 3, which I think we may be looking at tomorrow, we will look at weight-related issues throughout the life cycle. Right? And I did mention that there are supporting documents that is related to what we are talking about this week. So if you recall from, I believe, week 1 or week 2, we talked about how 2 out of every 3 Canadian adults are overweight or obese. We had this slide that said that. So essentially, Canadians live in an obesogenic environment. And this is an environment where it's very easy to be sedentary and very easy to eat because there are a lot of opportunities for you to eat, like with regards to availability of eating places, where they are located, the density of them in a defined area. So often individuals find themselves in conflict between the external environment, which provides them with many opportunities to overconsume, and the need to make healthier food and lifestyle choices. And so when we think of an obesogenic environment, the environment is designed in a way that is difficult to be, or it takes effort, much more effort, to be active, and then again, to restrict oneself from eating, from overeating. So when we just talked about what an obesogenic environment is, the opposite of that will be a leptogenic environment. And the photograph shown here is an example. And this is a staircase that is centrally located inside a building that provides an excellent view of the surroundings, and this is supposed to motivate people or individuals using that space to use the stairs. So some of you may recognize the staircase is on campus, and it's in the Rodman Center. So a leptogenic environment is an environment that supports healthy eating and healthy lifestyles as well. So what are some strategies for reducing obesity? So Naomi O talked about obesity last week, and she also talked about some of the consequences of obesity. Here on this slide, we're looking at some of the strategies for reducing obesity. So at the individual level, individuals will have access to information and tools that allow them to make changes to their lifestyle. And so very often we talk about small changes. Again, if they can be cumulative in nature, over time, they can improve health in an individual. And so there's a role that a person has to play in staying healthy. But in addition to that, one needs an environment that supports healthy choices. And that is key, because even when individuals are making healthy choices, but the environment is not supportive, very often it can lead down the wrong path, leading them off a healthy pathway to a more unhealthy choices. So in other words, we could have an environment that makes the healthier choice the easiest choice. We're talking about making the healthiest choice the most convenient choice. And that will be an environment that is supportive of good health. So right now, the modern environments makes it much easier to eat poorly. When we think about how fast foods, like the availability of them, and then how they are placed in neighborhoods, how accessible they are, it can make it difficult to eat healthy, especially in environments or neighborhoods. I don't know if we've heard of the term food deserts, where you have environments where essentially having access to a grocery store, easy access to a grocery store that carries fresh produce is difficult. And so in such an environment, very often these are low-income settings. In such an environment, one has to decide whether I'm going to use my money to take a bus to go to a grocery store in another community, or I'm going to use my money perhaps to buy food or anything I can get, right? So every dollar counts in such an environment. And so very often, if you live in a food desert, chances are the easiest convenient choice for you is not to travel a long distance to get that. Chances are you might not even have a car to be able to do that, right? And so having an environment that is supportive of good health is important, and it's as important as having individuals being well informed so that they can make these choices. Okay. So again, what happens in the setting where you're excited to eat healthy, you have all the information that you need as an individual, however, the foods that are available are not the healthiest. And so we do say that the food industry has a role to play, because if we look at the way we live today, most people are getting their food from grocery stores. And it has gone through some kind of processing. It might be minimally processed, it might be, medium level processed, or it might be really highly processed, right? And so holding our food industry accountable so that the food that is available is the healthier option, supports good health for the population, right? Because at the end of the day, people will eat what is available at the end of the day. No matter how excited you are about nutrition, if the only thing you have access to is what is there and is not the healthiest, at some point you're going to be hungry enough and you will eat that, because that's the only thing that's available. So the food industry also has a role to play. Okay. Again, we need to build communities where physical activity is easy. We should expect our schools and workplaces to provide food choices if they have cafeterias that also support good health as well. Okay, so this could be in the form of a workplace gym or cultures that encourage workers to go for walks during breaks or otherwise stay active. Okay, so when we think of supportive food environments, we need to keep in mind the drivers of food choice. Why do people choose the food they eat? It is a complex phenomenon when you think about how people make a decision to go and acquire specific food. And some drivers of food choice include affordability, which is a big one. It comes down to socioeconomic status. We can think of things such as accessibility. I just gave an example of if I live in a food desert and the next grocery store is in the next town, I have to take a bus and I don't have the money, I'm just likely to go to around the corner store that usually will not carry fresh produce, or it won't look like something I want to eat, right? And so those play a role as well. Again, convenience, right? We do not want to go out of our way to access healthy food, right? It has to be, and then lastly, but most importantly, it has to be tasty as well, palatable for people to consume that. And so in 2020, the clinical practice guidelines on obesity in adults was released. And as a guide to physicians and other healthcare professionals, this was a guide to help them manage obesity in adults. Unfortunately, this happened after the third edition of the textbook, so they don't have it in there. The textbook still has the 2007 guidelines about how to manage obesity in adults. So many of the recommendations from the 2007, they're incorporated in the 2020 guidelines. But then when you look at the 2020 guidelines on how to manage obesity in adults, there is new emphasis on patient-centered approach than the practices that were used earlier. So as we can see from the infographic here, we're just going to take it section by section. As we can see from the infographic here, the guidelines, they do emphasize what we call weight bias. So what is weight bias? It's an attitude that people with obesity, it's an attitude towards people with obesity. And often the thinking is that people with obesity, they lack willpower or are uncooperative. And weight stigma, very often it can affect the type of care that people with obesity can receive. Okay. So health professionals are cautioned to recognize weight biases that they may have and to ensure that they are not expressed in a way that will be detrimental to the health of a person with obesity. And so weight bias is thinking that people with obesity do not have enough willpower or are not cooperative. That's important to remember. And then we talk about stigma when we actually act on these weight biases, and it affects the kind of care that you give as a health professional or how you treat people with obesity as well. And this does not only affect the ability to access health, it can also affect, weight bias can go into how we recruit people for jobs, and can also affect the ability to access jobs as well. Okay. So when we look closely at the infographic, this part of the infographic, obesity is defined in the new guidelines as a chronic relapsing disease that is characterized by excessive body fats or adiposity that impairs health. Also noted on this graphic when we take a closer look is that BMI is not an accurate tool for identifying obesity-related complications. And I think we've talked about that in class as well, where we cannot use BMI alone to determine someone's risk for obesity-related complications. So the typical ones that we've talked about in class, we talked about type 2 diabetes, high blood pressure, and other cardiovascular diseases or risk factors, right? We talked about how BMI often has to be used with waist circumference because waist circumference has been seen to be a measure that measures like central adiposity, and that has a better link with outcomes, negative outcomes of obesity, such as high blood pressure and other things. So we cannot use BMI alone at the individual level to estimate one's risk of these types of diseases. So as an aside, it should be emphasized that BMI, when used in studies of large populations, right, it is considered a very useful tool. However, at the individual level, if you're presented in a clinic with an individual, you cannot make a decision just based on the BMI cutoffs. It's important to measure waist circumference as well in trying to understand the kind of risk this person will have for some of these complications that we talked about. So this part of the infographic now shows the 5 steps in the obesity management process. And it's often called the 5 A's approach because each step begins with the letter A. So we have the ask as step 1. Step 2, we have assess. We do have advise, agree on goals, and assist. I'm just going to get my pointer so it's easy to show things as I go through. And so the first step, as we said, is the ask stage. So let us take a second to see what the ask stage and the assess stage is saying. I'll give us maybe a minute just to take a look at it to see what ask stage is about and what the assess stage is about. I hope you have the slides closer and you can see the text. It might be a bit difficult to see it from here. Okay. So in the ask stage, this is the first step in approaching the management of obesity in adults. And the first step, respect and empathy for the person, is emphasized. So this is the patient. And what is required here is that you ask permission before beginning to discuss body weight issues. So weight is a sensitive subject because of the bias and the stigma that we just talked about, the weight bias and stigma issues associated with obesity. So just like any proper counseling technique, it is important to ask for permission before you start discussing issues around weight. Remember that the guidelines are supposed to support health professionals in different capacities to manage obesity. Okay. So this slide shows some more detailed description of step 1. And it talks about, this is what I just talked about, and it's saying that it's important to ask for permission to discuss body weight, and you will have to find ways of asking if the person feels their weight is impairing their medical, functional, or psychosocial health, okay? So an example is given, would it be all right if we discussed your weight? So there are people who are skilled at even being more sensitive in how they ask this question. And very often it's taught as part of motivational counseling skills. So I know Naomi O talked about motivational counseling last week. She mentioned it. And these are skills that are important for dietitians, and the doctors are trained to use that as well as a way of making sure they're being sensitive. Okay. So if the person is not ready to discuss any weight issue, you will offer resources about it, and then you will end the discussion. Because very often when people are resistant to the discussion or motivation, any form of counseling, it's like speaking to a tree, essentially. They do not hear anything, and it's not going to lead to any change. Okay. So the next step is to assess obesity. And under the step, the first step is to classify adiposity, and that is done by a combination of BMI and waist circumference. And then next to assess the impact that obesity is having on the health of the individual. So this step helps to tailor the counseling to the specific needs of the client or the patient. And remember, one-size-fits-all counseling often does not lead clients to make the needed changes, or even when made, they are hardly sustainable. Okay, so one needs to find that out. Again, in measuring disease severity, we can see another tool, a tool that is used. This is the Edmonton Obesity Staging System, and we'll see it in the next few slides. Again, this slide provides a bit more detailed elaboration than what we see in the infographic, and it focuses, it emphasizes, along with the assessment of obesity, to also learn a little bit more about the patient and determine their personal goals, because that is the only way you'll be able to tailor your counseling to their specific needs. Okay. So the example here that's being given here is being able to play at the park with grandchildren. And by knowing that that can be an important motivator that you use in your counseling to encourage the patient to make the needed change. So in the EOSS, it helps identify patients at elevated risk of obesity-related complications, and then it helps us to prioritize and focus medical interventions. It can be used as a guide to evaluate and monitor the effectiveness and progress of obesity treatments as well. Okay. So before we get into that, I think I show the Edmonton tool later on as well. I'm showing at the type of questions that are being asked there. Okay. So typically the EOSS, or the Edmonton tool, is a tool that asks questions about physical symptoms that they're experiencing. It also asks questions about functional limitations as a result of obesity. It will ask about psychological symptoms as well. And based on the responses that are given by the patient, there is a scoring of the responses and then a totaling of the questions. And now patients can be categorized into one of 4 stages in order of increase in severity. And so this helps with deciding what kind of treatment that needs to be given, in addition to knowing whether they have complications from the obesity as well. It helps guide a practitioner to decide what kind of treatment they should use. Again, this table from the guidelines shows the various classifications of BMI. And so the top classifications are the ones that I've shown you in previous slides, or you've seen in previous sessions. And it is essentially for individuals of European origin. So as you can see, there's a slightly different classification for South, Southeast, or East Asians, where the risk from overweight is found to occur at a slightly lower BMI. And it's important to use ethnically appropriate BMI cutoffs when they're available, because without them, you might miss some high-risk individuals, right? And so here we can see some of the differences between the cutoffs as well. So what is seen as normal, being considered European or North American ethnicities, when you look at Southeast populations, again, looking at that same normal range of 18 to about 25, when we look at the normal ranges here, it's again 18.5 to 22.9. So we can see the upper cutoff is a bit lower for this group or this ethnicity group as well. Okay. So the slide, which is this slide, which is also information taken from the guidelines, lists some of the limitations of BMI. And I think we've talked about some of the limitations of BMI already. It is mainly a measure of body size, where we are calculating body weight in kilogram over height in meters squared. It does not directly measure body fat or fat distribution. Is there a question? I hear a lot of talking in the background. I don't know if there's a question. So when we look at BMI, we can see it as body weight in kilogram divided by height in meters squared. And as we said earlier, it does not directly measure body fat or fat distribution. And it also cannot distinguish between body fat and muscle mass, right? So you could have someone with a high BMI just because they have high muscle mass as well, right? And is vulnerable to underestimating or overestimating body fat and disease risk in certain populations, as we've seen, because other ethnicities will have a lower cutoff point. Okay. So as indicated in the supporting documents on energy expenditure, waist circumference is a good indicator of visceral fat that is associated with an increased risk of things such as type 2 diabetes and heart disease. That is why it's so useful that in combination with BMI, you have to do waist circumference. So for example, athletes are some people who may naturally have high BMIs due to their higher muscle mass and may, based on BMIs, be classified as overweight or obese, but they're really not overweight or obese, right? So once waist circumference is included in the assessment, it becomes obvious that the individual is healthy. Okay. So here we see the EOSS, the Edmonton Obesity Staging System, a bit more closely. And we do see, as I mentioned earlier, it's used to assess the severity of the complications of obesity. And so it can range anywhere from stage 0 all the way to stage 4, okay? And so the example being a physically active female to individual with serious health problems in stage 3 and 4 with consequences, like those that are listed here, okay? And these will significantly impair one's quality of life. And so, for example, if we were to look at stage 4 a bit closely, we can see it's severe stage, potential end stage from obesity-related comorbidities, or severely disabling psychological symptoms. And so if the person reports depression related to the obesity, that will be something that will be looked at, and chances are that person will be categorized as a stage 4. And then severe functional limitations. So it could be as a result of the obesity, they are not able to move properly, they need help, or they're not able to do basic functions. And so that will also be categorized as stage 4 as well. So the next step in the assessment, and this is looking at another part of the infographic that I showed earlier. So the next step in the assessment is to determine some of the root causes of the obesity. So now you've determined by using BMI and waist circumference, you know which BMI category that they belong to. You have a good sense of whether their waist circumference cutoffs put them at risk of these obesity-related comorbidities. The next step in the assessment is to determine some of the root causes of obesity and consider some barriers to the management of obesity. So for example, poor lifestyle choices with respect to eating patterns, physical activity, and screen time are probably the main causes of overweight and obesity for many people, but there are more complex reasons, as well as internalized weight bias as well. So individuals often believe the stigma that the obesity is their own fault because they lack self-discipline, and sometimes the response to this is to avoid addressing the health issues that are related to the diet, which is counterproductive. So many other disorders listed here can contribute to the development of obesity, such as mood and anxiety disorders, factors such as addiction, a history of abuse, so trauma, certain medications that cause weight gain. And then if they have endocrine disorders, they can all contribute, and some sleep disorders contribute to weight gain. And so it's important to ask about these conditions in determining the cause or what is driving the obesity you see. Again, looking at potential root sources that are summarized up here. One important one would be socioeconomic status, which influences one's food security status. There are also factors, because we know food insecurity refers to the inability of an individual to access adequate amounts of nutritious food, usually as a result of financial limitations. So it may seem counterproductive when you think about food insecurity, because when we're talking about food insecurity, it's not that they are calorie deficit, but then they might be nutrient deficit, meaning the food is not nutritionally dense, but they are having some calories, and there can be overconsumption of the calories. Okay. So some of the consequences of obesity can also become barriers to treatment. So for example, if someone develops osteoarthritis, which refers to the breakdown of cartilage in the joints, such as the knees, it often, which is often resulting from stress as a result of having an increased adiposity, stress on your bones, okay? Osteoarthritis can now become a barrier to them in being more physically active, because it's not possible for them to move around or just be active in that way. So after step 2, we move to step 3, and this step is to advise on weight management, and this usually involves nutrition therapy, exercise, psychological support, and it may also include the use of medications, and sometimes the use of surgery as well. So in surgery, very often we're looking at bariatric surgery. Again, just to give you a closer view about the elements of advice in more detail. And so the first one will be medical nutrition therapy. So this is where you have personalized nutrition being provided to support the weight loss, like healthy diet, with the aim of making sure that you will end up reducing the weight significantly and can improve or remove some of the risk of developing these comorbidities. And very often this is done by a dietitian. And so Naomi, who came last week, is a registered dietitian. And it needs to become a registered dietitian. I think I'll just use the opportunity to talk about that a little bit more. You receive extra training in a health facility and in a community setting to give you, hands-on skills on how to do counseling, on how to understand people's situation and use that to give them the needed advice. So that's a bit different skill that is required from RDs than just a nutritionist. Okay. Again, physical activity, we see the recommendation of 30 to 60 minutes of aerobic on most days of the week at moderate to vigorous intensity, and it talks about what it can yield. Here we see the 3 pillars of obesity management that support nutrition and activity. Of course, they will give like a cognitive part to this, because a big part of obesity is linked to the psychology of the person as well. And so there are interventions. Most well-designed interventions will have a psychological intervention piece to it. And then there are pharmacological approaches where medications are used to help with losing weight. And we can see here that very often the BMI has to be over 27 kilograms per meter squared. And then surgery, we can see the cutoffs are even higher for the criteria you need to meet to be eligible for surgery as well. So on this slide, we see some of the messaging that is recommended when having conversations with people living with obesity, and it focuses on the importance of nutrition for everyone. It encourages the patient to find a suitable, healthy eating pattern that they can sustain over the long period, and so restrictive diets are usually not proposed in a healthy designed intervention for obesity, because very often they are not sustainable in the long term. Okay. And there is often an emphasis to avoid dieting, that is, going for a very restrictive diet, or severe food restrictions, and it almost always leads to weight regain in the short term or in the long term as well. Okay. So in talking about healthy dietary patterns, there are a number of them that we've mentioned in this class already. And we can see Canada's Food Guide, which the newest version, the 2019 one, supports a healthy eating pattern. We talked about the Medi diet, which is the most researched diet that we have and has often been linked to healthy outcomes as well. Vegetarian diet, portfolio diet. So the portfolio diet, we talked about it, and the aim is really to help reduce cholesterol intake in the diet overall. This was developed by a U of T professor in the nutrition department. We've also seen what low glycemic index foods are. So there are diets that are based on this, and we did see examples of this being used for diabetic patients, so type 2 diabetes, where there's a recommendation to eat most foods from low GI foods and moderate GI foods. We talked about the DASH diet, and the DASH diet was mentioned when you were looking at lipids. And this diet is really designed for people with high blood pressure, and the aim is to reduce consumption of unhealthy fats and also increase fruit and vegetable intake as well. There may be others that you may know that is not shown here, but then it's important to note that those that are listed here have been researched to some extent, and as I mentioned, the Medi diet is the most researched one that we have. Okay, so there are some situations where some weight loss is recommended specifically to reduce the risk of progressing disease. So a good example will be when one develops prediabetes. So if you recall, we talked about prediabetes is when your body starts struggling with reducing your blood sugar, but you don't have full-blown type 2 diabetes then, okay? And so with prediabetes and type 2 diabetes, a modest weight loss of about 5 to 7% of body weight is recommended. And so to slow down the progression of type 2 diabetes, if one can minimize, and to help minimize the development of serious complications, weight loss of about 7 to 15% of body weight is recommended for those who already have type 2 diabetes. So this is an example of cases where weight loss is encouraged to help with management of these diseases. Okay. So the final steps in weight management, we've seen steps 1, 2, 3. We're now looking at step 4. We'll look at step 4 and 5. And what we're looking at here is agreeing on the goals with the patient or with the client, because at the end of the day, the patient is the one going to make the changes. And so out of all that you see from the drivers of the obesity that you're seeing in the person, you want to agree with the patient which ones they would like to work on first. And by having that approach, it's intended to have buy-in from the patient to be involved in the process, and to see it more as something that they are doing instead of something that the professional is pushing on them to do. Okay. And so after you have agreed on these steps, and then you can assist with the drivers and the barriers as well as the last final steps here. So this slide details the agree and assist steps, and the main feature here are that the plan is personalized. And you can only have a personalized plan if you took time to know what is driving the obesity from the start. Again, the hope is that at this point, by the time you get here, you will be able to come up with a sustainable plan, and then also be able to provide support to the patient. And so in providing support, very often you would ask the patient about when you can meet again, right? Very often, departments that help obese people will also have a support group. It could be a peer group. It could be a group of professionals with other people. And this is all in efforts to assist with drivers and barriers by having a support group where they can talk about what they're struggling with or what they need help with, so they can be addressed in a timely fashion. And you will schedule appointments with a patient to check in to see how they're doing with their goals as well. Okay. Okay. So next, what we want to look at is the characteristics of a healthy diet. And so in the next few slides, I will detail some strategies with respect to food choices and physical activity that can contribute to sustainably support a treatment plan. There are many commercial diets programs that are advertised to individuals and many more diets that are promoted on the internet. But this table shows the differences between a healthy diet program and a fat diet. So a healthy diet provides a variety of foods, whereas a fad diet can often be recognized for limiting a large number of foods or entire food groups from the diet. The problem is that you can have some nutrient deficiencies happening when you are restricting like food groups out of a diet as an attempt to lose weight. And again, as we said, when you're removing whole food groups, it makes it difficult to adhere to this diet over the long run and achieve the goals that we're looking for. So a healthy diet and a healthy weight loss program, first of all, it will focus on changing behavior and teaching appropriate eating habits for the long term. And good programs provide social support, as we mentioned, and then access to health professionals. So whether you are paying for a program or just getting one through a health professional, it's important to see whether there are trained professionals such as RDs supporting this effort, medical physicians who are supporting this effort as well. And that's an important feature of a healthy diet program. Okay. So we do see, just to highlight a few of the things said here, it should plan to give you reasonable weight loss. So if there's a diet that is telling you can lose like 40% of your body weight in a couple months, chances are it's not the best. I mean, you might achieve it, but you might gain it as quickly as you lost it once you get off the diet. Physical activity, there has to be a physical activity component because physical activity doesn't just help with losing some of the fat, like the adiposity, using some of that, but it also helps to build the muscle, which is metabolically active. And so by being metabolically active, it helps to reduce weight as well. It has to be flexible. It has to not contain costly supplements. Again, thinking about the sustainability of this. Are you going to, if you have expensive supplements, is the person able to pay for these in the long term? After 10 years, will they still be paying for the supplements? And then it promotes beneficial behavior change. And then it has to be scientifically sound. That's very important, that it's supported by scientific evidence as well. So this table lists some strategies that can be used to reduce the amount of food consumed. And very often this is taught in efforts to lose weight as part of the nutrition therapy that is given. Okay. So the tips shown help monitor serving size. And the first tip is to pour a serving of chips into a bowl rather than eating it right out of the bag, because chances are you'll finish the whole bag. It's well recognized that if one consumes food out of the bag, one tends to eat until the bag is empty. And so maybe pouring a little portion of what you want to eat in a bowl might be, little strategies that might help. And so this is a good example of mindless eating, In the CFG 2019, it talks about mindless eating. And so eating there has to be some intentionality to it, where you're taking steps to avoid overeating or eating the wrong things. Here are some additional tips on how to reduce the amount of food consumed, especially those that are high in calories. For example, you can simply consume less of a food or substitute lower calorie food. So just one example from here, water instead of soft drinks, switch to a low-fat milk so that you can reduce how much saturated fats that you're consuming from the higher fat milks. Okay. So one other strategy that is used, again, in nutrition therapy is to reduce the energy density of the foods that you're consuming. So you're reducing the caloric amounts of the foods that you are consuming. Energy density is the number of calories per gram of food, and it's known that feelings of fullness or satiety are related to the volume of the food that fills the stomach, not the total calories it consumes. So one can feel fuller on a lower calorie food, for example, like soup, shown here, compared to 1/6 of a burger that's also shown here, even though they both have the same amount of calories. So by consuming this, because it fills up the volume of the stomach, one has a perception of being satisfied more than if they ate just 1/6 of a burger, but both of them are given the same amount of calories. Okay. Another important tip that is given in nutrition therapy is that simply do not drink your calories. So it's a good thing to avoid sugar-sweetened beverages because they provide no nutrients and they simply add calories to the diet. And it's seen that if you had, for example, if you had a soup that was about 1,000 calories compared to drinking sugar-sweetened beverages, that was 1,000 calories. Although they are all filling the volume, it's seen that satiety with the soup is perception of satiety is higher than what you get from sugar-sweetened beverages. So you could consume about 1,000 calories in the sugar-sweetened beverages and still feel hungry after consuming that. And that is one of the reasons that it's recommended to consume water, in addition to it contributing to too much free sugars and also contributing higher calories as well. Okay. Another one of the features, and we'll take a break soon after this part, it's also important to eat often enough so that you don't get too hungry. Because once you starve yourself, you're very likely to overcompensate, so overeat on the next meal. And so making sure that you're eating enough meals. And you may recall this slide, we've seen it earlier in one of our sessions. And physical activity, we talked about how physical activity can be categorized into, like physical activity levels can be categorized into a number of groups. So we saw the sedentary, we saw the low active, we saw active, and we saw very active, right? And we also, when we're looking at this, we talked about how many more calories that one needs to burn as you move from sedentary all the way to very active, right? And so physical activity, as you can see, you may not be expending a lot of calories to make a huge difference in weight loss immediately. But what happens with physical activity is that it helps to build muscle, which is metabolically more active and will raise one's basal metabolism. And so by doing that, it is able to help with weight loss because your basal metabolism is now increased, okay? Furthermore, an extra 100 kilocalories a day of expended energy is very helpful in maintaining weight loss, right? And so you can think of physical activity helping in a number of ways. First of all, building metabolically active mass, and then being able to expend more, which helps with weight loss as well. And if you recall, when we're looking at type 2 diabetes, we talked about how physical activity is also able to help with the uptake of glucose from the bloodstream, independent of insulin as well. So that will be an added advantage of physical activity as well. Okay. So I think we'll take a 5-minute break here. And when we come back, we'll talk about cognitive behavioral therapy.
So I usually take all the quizzes on Sunday because that's what
Right.
I do. But this one, I found it was like due on like this Wednesday.
Wednesday.
I already took it, and I just found out because I was taking it. I'm like,
Right.
why are like the 5As like I haven't seen that, and like I was looking for
Right,
the textbook
right.
that the BMIs like for the like,
Okay, so I don't know which one's on now. Okay. So I think we can move on with our discussion. So as part of the 5 A's, we saw a highlight of psychological aspects of the intervention that is given. And so this is in line with the cognitive behavioral therapy. And I just wanted to spend some time to talk a little bit about that. And CBT, as it's often called, is recommended as part of treatment when it comes to obesity in adults. And this slide illustrates the aspects of CBT. So in order to improve behavior, one has to break it down by recognizing the cues that lead to the eating behavior. So these cues that lead to the eating behavior is also called antecedents. So that is what you will see on this side. Okay. And so in the example shown here, the antecedent is the television set or TV watching. Okay. And certainly eating in front of the TV can lead to overeating, as we tend to eat mindlessly in front of a screen. So in this graphic, we see at the top the typical behavior in that someone sits down in front of the TV and they eat a bag of high kilocalorie potato chips. And so this is something you find out again during step 2 when you're trying to understand what is driving the obesity in this person. So we can think of it as one of the examples or one of the things that was shared by the patient, that they tend to eat a lot of chips when they sit in front of the TV. So in this graphic, we see what is happening at the top as the typical behavior, eating to consumption of potato chips, like a whole bag of it. And this is contributing, the consequences, the obesity, contributing to the obesity that we're seeing. And so in CBT, a person becomes aware that the TV or watching TV is a trigger for eating chips. And instead, we may not be able to say do not watch TV at all, because that will take a long time to achieve. And so what we will do, or what will be recommended in CBT, is to see if the patient can replace the high calorie snacks with a lower calorie alternative, right? So that the cues are still happening. However, a low calorie alternative is used to reduce the negative consequence. So in essence, if this is something that is happening daily, multiple times, by introducing a lower calorie alternative, it will be able to reduce the weight gain or limit the weight gain a little bit more. And so when we talk about the ABCs of behavior, one has to know the antecedents or the cues that lead to the behavior. They have to know the behavior itself, what actually is the problem, and then the consequence that is being experienced. And then we can try to alter the behavior by introducing something that is helpful for a healthy life or supportive of good health. Okay. Again, when we're looking at the 5A's, we saw that sometimes pharmacological approaches are used in interventions, and I'll talk about a few of these medications that are used to help with obesity in a second. So for some cases of obesity, if you recall when we looked at that slide, there has to be specific criteria, cut-offs of BMI that has to be met before one can be given medications. And so for those cases where health complications occur, pharmacotherapy and surgery can be included. And so now in Canada, there are 3 drugs, well, in the past, 3 drugs, but then a few more now that I will talk about today. So one is Orlistat, and Orlistat works by reducing the absorption of fat. And so it inhibits the enzyme lipase, right? And so fat is not optimally absorbed. So as a result, fat in the diet goes unabsorbed, and it does not contribute to kilocaloric intake or energy intake. So one also has to be careful when taking this drug, because if too much fat is unabsorbed and it goes into the large intestine, you can have uncomfortable symptoms such as soiling yourself, because the fat is just coming out and it's not being held together with the fecal matter. Okay. So other problems with that can be related to taking this medication, Orlistat, is the fact that we know that fat-soluble vitamins are usually absorbed with our fats. And so essentially, if you are not absorbing the fat, you're also missing out on your vitamin A, D, E, and K. So those are your fat-soluble vitamins: vitamin A, vitamin D, vitamin E, and vitamin K. Okay. A second drug that is widely used for weight loss is liraglutide. Okay. So the drug was first approved for individuals with type 2 diabetes, as it stimulates the secretion of insulin to help control blood glucose. So when they were doing the trials for this drug, it also found that it tended to suppress appetite and cause weight loss as well. So it's an often prescribed medication for individuals with BMI greater than 30, and especially if the person has complications such as type 2 diabetes, this will be prescribed to help manage blood sugar and at the same time help with losing weight. Because we know that as weight loss happens, there can be remission of type 2 diabetes if you lose weight to optimal levels. So the other one that's not shown here that I will talk about, so maybe first of all mention that there are side effects of liraglutide, and that's constipation and gallstones. So there is another medication that might be well known now, recently introduced in Canada, but it has been prescribed in places like the UK for a number of years. So this is a tirzepatide, and its market name is Mounjaro. You may have heard of Mounjaro or Zepbound. So these are medications that are also out there. And what it does is that it acts as what is called a dual agonist for GIP and GLP-1 receptors. So we'll talk about gut peptides in our lecture today. So GIP, GLP-1, these are gut peptides or hormones. And often Mounjaro or this other medication is given as weekly injections. And what they do is they're able to suppress appetite because they act the same as these gut peptides and in suppressing appetite to large extents, and it often leads to significant weight loss as well. We've heard of names such as Ozempic. Ozempic is a semaglutide. It's not a tirzepatide. And so what it does is that it doesn't have a dual action such as we have for Mounjaro. Ozempic acts only on GIP or GLP receptors to suppress appetite. And so what is happening now in the market and in treatment of type 2 diabetes and again weight loss is the use of Mounjaro. That's a more common drug that is being used now. But then you have to meet very specific criteria for it to be prescribed for you. So there are few people who just buy it off the market and use it, although they might not meet those criteria, but they do use it. I don't know if you've heard about, people talk about the Ozempic face, where there's so much weight loss that the face looks old in just a few months, right? Yes. I don't know if it's over the counter, but people find a way. There are online sites that will sell them to you, even if you don't meet like the standard of practice guidelines for it. But people find ways of buying them. Yeah.
I know also that sometimes there are drugs that are over the counter in other countries.
That I don't think it's over the counter in the UK. At least I know about the UK because they've been using Mounjaro for a while. It's not over the counter, but people just find ways of making things happen. Yeah. Okay, so our last drug, this is a weight loss combination drug. This is the third one that we are talking about. And this is made up of two drugs. Naltrexone, it is an anti-addiction drug. And then bupropion, which is an antidepressant. And again, this drug combination is recommended only for individuals with very high BMIs or for those with BMI who have serious obesity-related complications, especially if one of the complications is depression. It will be recommended for them. Okay. So we've talked about CBT, which is the psychological approach or treatment. We've talked about some of the drugs that are used for weight loss, so the pharmacotherapy. Now we want to look briefly at surgery, the use of surgery, bariatric surgery or gastric bypass for these. So this will be the most extreme cases of obesity, and bariatric surgery is recommended, which reduces the size of the stomach. And in addition to reducing the size of the stomach, they redirect food, bypassing the initial part of the small intestine and introducing the food into the middle part of the small intestine, okay, where many nutrients are absorbed. So bypass surgery was one of the short topics that we discussed in week 4, if you recall, when we're looking at topics that were related to the gastrointestinal system. And so if you recall, someone with this kind of surgery has to be careful not to overeat because of what we call the dumping syndrome. And we explained the dumping syndrome as discomfort that happens from eating too quickly and having food be introduced into the middle part of the small intestine too quick. And that can lead to things such as fainting, discomforts with the stomach and vomiting as well. And so because a part of the small intestine that is bypassed is responsible for absorption of, you can think of things such as vitamins, minerals, individuals with surgery who go through this bariatric surgery will have to live like a lifetime of taking supplements, right, that are absorbed by just having high concentrations for the rest of their lives. So I know this is a favorite singer that I like. You may be too young to know her. So this is an example of changes that can happen. And she publicly stated that she had bariatric surgery done, and we can see the change as well. I don't know if you're interested in that kind of music. She has a really nice rendition of Swing Low, if you're interested in soulful music. So we also talked about how weight loss and sustaining it over a long period can be so difficult. We've seen a number of strategies that is used to support weight loss or just to manage obesity. And it's important to state here that 90% of people who attempt weight loss usually gain it back. Okay. And it is recognized that we live in an environment, some of the reasons include the fact that we live in an obesogenic environment that is just not supportive of an active lifestyle and eating healthy. Okay. Again, other reasons that make weight management challenging for many people is rooted in human physiology. And we'll talk about that as we go through the next discussion in section 2. So it's almost like our bodies always take us back to the set point. And we'll explain the set point theory a little bit more and talk about how gut peptides are involved in some of these processes as well. And this is a slide we've seen, I think, in week 2 when we're just doing an overview of what we'll be talking about in the term. And here we can see a regain of body weight going up to 60% and even higher after that. So this is showing percent weight regain over duration of follow-up. So 1 year after follow-up, 2 years, 3 years, in that order. And we can see that up to the 5th year, people are gaining almost 100% of the weight that they lost. Okay. So this brings an end to section 1. We want to move on to talk about section 2. In section 2, we'll be dealing with regulation of food intake, and we'll explain why some of the strategies for weight loss are so often unsuccessful. This is a summary of everything we looked at in section 1, looking at the 5 A's, the different steps, right from step 1 to step 5. And so we are asking, we are assessing, You advise on management, you agree on the goals to get a personalized plan, and then you assist by providing support. So in the second part of our discussion, we'll be looking at food intake regulation, and then we'll look at how the body is designed to protect us from starvation, and then look at leptogenic environments as well. And in order to understand some of the challenges that we have with weight management, it's important to understand how food intake and energy expenditure is regulated in the body. And so there are three terms used here, and very often in everyday English, it's used interchangeably, but then in nutrition, they're explained a bit differently. And so when determining how food intake is regulated, we often assess characteristics such as hunger, we will measure satiety, and then we'll measure satiation. And I'll talk about the differences in a second. So when we look at hunger, we're looking at internal signals that stimulate someone to acquire and consume food. That's how we will define hunger in food regulation literature. When we talk about satiety, we're looking at feelings of fullness and satisfaction that is caused by food consumption, and this is what leads, it eliminates the desire to eat more, okay? Very often, this satiety is what you experience after a meal, and it will determine when next meal will occur, okay? And then we talk about satiation. Satiation is the feeling of fullness that develops during a meal, and it determines when a meal will end, okay? So when you're eating, when you start feeling satisfied, that is what we're referring to as satiation, right? That is what determines the end of a meal, okay? So there are two questions that we're asking here. First one is, what regulates body weight or energy balance? And then, why are some individuals able to maintain a healthy body weight while other individuals struggle with problems of overweight and obesity? Okay. So first, we want to start with the evidence that we have when it comes to food intake, energy expenditure, and fat metabolism. So there's a lot of evidence to support the idea that this is not just about personal choice or lifestyle choices, although we know that at the end of the day, someone has to decide to eat the food before they have excess calories. But there are, in fact, specific genetic and physiological factors that make it difficult for many to lose weight, and especially to keep the weight off. So we know that genetics play a role in weight management, and we'll look at some of the evidence for this in a moment. So genes that are involved in regulation of food intake, energy expenditure, or fat metabolism will influence body weight. And we know that there are variations in these genes that influence these three things, and their functionality between individuals as well. Okay. So from the research, we know that parents and children, siblings, twins, they are more similar in their body characteristics than unrelated persons. However, when we're looking at fraternal twins versus twins that are identical, identical twins tend to have more relation when it comes to how food intake, energy expenditure, and fat metabolism happens compared to twins that are not identical as well. And so there are genetic differences, and a lot of studies do tell us that these differences do have an impact on body weight and its management in the long term. There's also the concept of set point theory. So this means that a body tends to defend a predetermined body weight, okay? And it's of course a very common observation that after people lose weight, they usually return to their pre-weight loss weight, or sometimes they even gain a little bit over and above their starting weight. And this is believed to be due to talk of it as a quirk or a quirk in our human physiology. So the body is unable to distinguish between weight loss that involves moving from a healthy weight to a low unhealthy weight, or weight loss due to serious food deprivation or starvation. Okay. Or it cannot also tell the difference between a change in body weight that's moving from someone from perhaps a high and unhealthy body weight to a healthy body weight. When the body senses a loss of weight, human physiology is programmed to protect it by taking it back to the set point where it started from. And so there are changes or adaptations in the physiology of a human that takes it back to that higher weight point. And that's because the body doesn't know, oh, we are in a starvation situation, and that's why I've lost weight, or I'm losing weight from a healthy weight to a lower weight. It cannot tell the difference between that. So we've talked about genetic factors. We've talked about the set point theory. These are factors that do affect body weight. Another factor is hormonal activity. And so hormonal activity also plays an important role in regulating appetite. And we'll talk specifically about gut peptides here. These are peptides that are produced in the digestive tract, and they are responsible for short-term regulation, and they do influence food intake at meals and between meals as well. For our discussion, we will discuss two of many gut peptides. We'll be focusing on ghrelin and GLP-1. As we talk about these two, ghrelin and GLP-1, we will also introduce the hormone leptin. So leptin plays a role in regulation, short-term regulation of food intake, but it's not a gut peptide. But we will talk about it because it has an influence on food intake as well over the longer term. So let's start with ghrelin. It's a gut peptide, and it's a hormone that is secreted by the stomach that stimulates eating. Okay. So levels of ghrelin usually rise before a meal, stimulating hunger, and then the levels in the blood go down or they decline after a meal, reducing hunger. So there are other hormones that are secreted by the small intestine to suppress food intake. And as I said, I have selected one. This is GLP-1, glucagon-like peptide 1. Okay, it's not written out here, so if you want to write it down, that's my mistake. Glucagon-like peptide 1. Okay, so GLP-1 also stimulates the release of insulin, and there are other polypeptides such as peptide YY, a number of them, but we won't talk about that. We'll be looking at just ghrelin and GLP-1. So important thing to remember on this slide is that ghrelin stimulates hunger, and when we're looking at GLP-1, it suppresses hunger, okay, and stimulates the release of insulin. So if you remember when we talked about some of the drugs or medications that are used to help with losing weight, they are GLP-1 agonists. And what that means is that they are able to act like GLP in suppressing appetite. Okay, and that's how they are able to help with weight loss. Okay. So this is a graphic that shows the effect of ghrelin and the differences between lean and obese individuals. And although it may seem a little bit counterintuitive, obese individuals have lower levels of ghrelin in their blood. So that's one important thing to remember. Obese people generally have lower levels of ghrelin. And it's counterintuitive because you will expect that if ghrelin is what makes you hungry, it stimulates appetite, then why is it that obese individuals have lower levels of ghrelin? But we'll talk about that in a second. Okay. One other thing that is important to note, so on this graph we can see for leaner people, the higher levels of ghrelin, and for obese people, the lower levels as well. Okay. So during a meal, the decline in ghrelin is a much, how do I say, it's not as sharp as we see it for leaner people as in obese people. So when you look right here, this is when you have the meal at time 0, and then look at the decline after the meal that you see for leaner people compared to obese people. And so we see a sharp decline in ghrelin, meaning that appetite is suppressed very quickly in leaner people than what we see in obese people, right? And so in obese persons, you see a reduction, but it's not as steep as what you see for leaner individuals. Okay? And that is important to note because if you recall when we talked about satiation, the feeling of fullness that develops during a meal determines when the meal will end for that individual, right? And so reduction in ghrelin during a meal is believed to determine the end of that meal. And so if your reduction in ghrelin levels is not happening quickly, then essentially what is happening is that you're going to eat a meal for a longer time. And so that is what is observed in obese people, right? That their responses, they have a blunted response to ghrelin. And so they might eat a bit more during a meal compared to a leaner person. Okay. So why is it that we have differences? Why is it higher in lean individuals, ghrelin higher in lean individuals compared to obese, like generally when you look at levels? Ghrelin levels, when a body is in a state of negative energy balance, and that's what you typically will find in a lean person, right? Negative energy balance is they're able to lose weight because their intake is lower than how much they're expending, right? Ghrelin levels increase to signal the need for more food intake to restore energy balance. And so typically you will find leaner people having higher levels of ghrelin than obese people. However, there's that blunted response to ghrelin in obese people, which makes them eat meals a longer time before they have satiation. And that might be driving the weight gain that we see. Okay. And so when you look at other literature, it also talks about ghrelin concentrations being inversely correlated with BMI, right? And so the higher your BMI, the lower your ghrelin levels. And then the lower your BMI, the higher your ghrelin levels. And that's why we see these differences between the two. So when you compare lean and obese people, or obese individuals, GLP-1 levels tend to be lower in obese individuals compared to lean individuals. And because GLP-1 suppresses food intake, lower levels could predispose individuals to weight gain. And so when drugs that mimic GLP-1 or prevent its degradation are used, people tend to lose more weight. Okay? And we talked about liraglutide mimicking GLP-1 as well when we went through it. And so what to remember from here is the fact that GLP-1 levels tend to be lower in obese than lean individuals. Okay? And GLP-1 is supposed to have a suppress your appetite. And so if you have lower levels, then you don't have as much suppression as we would see in a leaner person. Okay. So in addition to gut peptides, the hormone leptin, which we talked about, we said it's not a gut peptide, but it's a hormone that's also involved in food intake regulation. Okay. We have the hormone leptin, which is also secreted into the blood by adipose tissue in proportion to the amount of adipose tissue that you have, so the fat tissue that you have. So leptin, the levels of leptin that is produced is in proportion to how much fat tissue you have. And so keep in mind, by saying this, we can just infer that obese people will have more leptin production than leaner people, right? Because how much is produced is in proportion to how much fat tissue you have, okay? So leptin acts on the brain and it regulates food intake. specifically leptin, will reduce food intake. And we know that the absence of leptin stimulates hunger, and it's through these signals that a constant body weight is maintained. So in a lean person, for example, looking at the figure, we see the adipose tissue at its set point, its typical size. And if there's weight loss, the levels of leptin drops, and this absence of leptin will stimulate hunger and food intake, and also decrease energy expenditure. These functions, in turn, will stimulate weight gain and return the adipose tissue to the set point. So what are we saying? We're saying that leptin levels are related to how much fat tissue that you have. And so in the case, if someone lost weight, they lose some of that fat tissue. And so as a result of that, leptin levels that are produced will be reduced as well. Remember that leptin suppresses appetite. So when you have less of it, that means your appetite is going up. And so you end up consuming a bit more, and that's how you end up going back to your set point. That's what we're seeing here. Okay. And so if in a case, if we're looking at a lean individual that should consume increasing amounts, then the amount of body fat will go up. There's an increase in body fat because you're consuming more. And this is all talking about a healthy individual, a person who is leaner. Okay. And so with the increase in body fat will come an increase in levels of leptin. And this leptin will decrease food intake. And this, because the food intake is reduced, this will regulate the metabolism and then bring the weight back down. And so in a lean individual, these mechanisms are supportive in keeping the weight at almost the same point, maintaining the weight. However, in an obese individual, there are differences that are seen. When this system, the action of leptin, works well, most people can maintain a constant body weight. And this is typical of what we see in leaner people. However, it's a bit different when we're looking at what happens in obese people. Okay. So when we compare obese individuals to leaner individuals, we find that leptin levels are higher in the blood of obese people, as you will expect, because they have higher adiposity. But the body doesn't respond to this extra leptin in the same way that it will respond to in a leaner person. Okay. And this is because the absence of leptin is a stronger signal to promote hunger and eating than the presence of leptin to suppress hunger. And this actually makes sense if you think about it from the point of view of evolution. You don't want a regulatory system that suppresses food intake too efficiently, as this could risk the survival of the organism. Okay. And so this insensitivity that we only see in obese people to the stop eating signal of leptin is called leptin resistance. And this is a difference in metabolism that is observed in obese people. In leaner people, you have these changes in leptin working efficiently to maintain a constant body weight. However, in obese people, although they have higher levels of leptin, you can think of it as leptin, because of the leptin resistance, they do not have that suppression, that effective suppression that could lead to weight loss as well. Okay. And so most obese individuals are leptin resistant. Okay. So let's think about what happens when someone tries to lose weight. The leptin levels go down during weight loss. What happens to leptin resistance during weight loss? It will also go down. When someone has lost weight, their leptin levels drop and they become more sensitive to leptin. But keep in mind that at the same time, they are becoming more sensitive to the absence of leptin. And the absence of leptin will stimulate hunger in this person. So when you think of it carefully, one can see that weight loss has embedded in it its own source of, you can think of it as its source of its own failure. And the decline in leptin levels has a built-in stimulus for food intake and weight regain. And so these hormonal and physiological programming are very helpful if you are actually starving, as it promotes food intake and food-seeking behavior to make sure that you survive. However, this is not so good if you are overweight or obese and trying to reduce your weight to a healthy level. And so this is where we see most people reverting or going back to the set point theory because of some of these physiological differences. And so what happens to weight loss during, what happens to leptin levels during weight loss? The leptin levels will reduce. What is happening to leptin resistance during weight loss? Your leptin resistance reduces. But what effects do these changes in leptin levels and leptin sensitivity have on food intake? You will have your food intake increasing, right? And that's why it may be very difficult to lose weight and keep at it. And it takes considerable effort to keep the weight off once you have gained it. Okay. So we just talked about leptin and how it influences metabolism, and it looks very different when you're looking at a leaner person compared to someone who is obese. And the hormone leptin regulates energy expenditure by a process that we call adaptive thermogenesis. And this means that when someone overeats, the body will adapt by increasing energy expenditure, and this will result in the maintenance of a constant body weight. On the other side, if you undereat, you will maintain a constant body weight by conserving or down-regulating your energy expenditure. And this adaptive thermogenesis can adjust energy expenditure by several hundred calories in either direction, depending on what you're doing. Okay? And so we can appreciate better how someone whose body is able to easily up-regulate energy expenditure, perhaps because of their genetic predisposition, will be able to maintain a constant body weight more easily than someone whose genetics makes them better at conserving rather than expending energy. They will more easily gain weight. So typically, energy expenditure can be varied by up to 250 kilocalories in either direction, but research has shown a lot of individual variations also exist as well. Okay. We've seen that adaptive thermogenesis differs between lean and obese individuals, because when we look at, in terms of weight loss, we know that in response to weight loss, there's a decline in basal metabolism or basal metabolic rate, but that is known, and this is only seen in people who are obese. So first off, let's start with here. So there's a decline in basal metabolism in response to weight loss, and it's more pronounced in obese compared to lean individuals. Again, putting them at a disadvantage when it comes to maintaining the weight. And so essentially what we can say from here is that obese individuals, they conserve energy more effectively. Increase in basal metabolism in response to weight gain is less pronounced in obese compared to lean individuals. And so we do see that lean individuals, they expend energy more readily. And so for an obese person, they're holding on to energy more effectively, and they do not expend as readily as you see in a leaner person. And that's what puts them at an increased disadvantage of gaining even more weight as well. So keep in mind that there are practice questions for section 1 and section 2 that have been provided on Kirkus. And these are just to see if you understand some of the concepts that we've talked about today. Moving on, our third part, we will be discussing how weight concerns may vary throughout the life cycle. So under this section, I do provide a case study, and that case study is about weight management in adolescents, and we'll look at that tomorrow. Please take a look at it. It's also in your textbook, but I have attached it. There's a link there that should take you to it. And you want to make sure that you can answer the questions that are related to it as well. So if you take a read, we will do that. We'll work on it together in class when we meet tomorrow. So before we go, just want to introduce it a little bit, and then tomorrow we can just spend the whole time just going through the case study and taking questions and answers if we have time at the end, okay? it's important to know that body weight changes during pregnancy and lactation. There are different rules and guidelines with regards to body weight and adolescence, so like obesity during this period or weight gain during pregnancy, and also weight gain implications when it comes to the older years as well. And we'll be talking about each stage separately. I think we do have a few more minutes, so I want to just go through the physiology of pregnancy and then we can go. So women do gain weight during pregnancy, and most of that weight is lost at delivery. And I say that with an asterisk to it, because if women typically gain more weight than is recommended, it doesn't all go away after delivery. Okay. And when optimal weights are put on during pregnancy, that leads to very healthy outcomes for both the mother and the infant that is born. Okay. And so when we look here, we can see different, like a total of 11.5 to 16 kilograms is what is recommended. On average, it's about 12 kilograms is what is recommended for a woman who goes into pregnancy at a healthy weight. So you can think of BMI in the normal ranges. Keep in mind that there are ethnic specific ranges as well. But starting from normal, it is recommended that you gain about 11.5 to 16 kilograms. And so we can see about 3.6 kilograms of this weight goes to the developing fetus. And so it's typical to have fetus around this weight when they are born, all the way from 3.2. This will be a full-term healthy infant. There is a part of this weight that is as a result of development of the amniotic fluid. So this will be the fluid around the fetus in the womb that helps protect the fetus from shocks. Okay. And then there's a part of it that goes to the placenta. And we can think of the placenta as that organ that is developed in pregnancy that is able to link the mother to the infant and help with provision of nutrients and taking away of substances, toxic substances that are excreted. And then again, formation of the uterus. Keep in mind that the uterus thickens. The lining of the uterus thickens during pregnancy so that it can carry the fetus. And so this is responsible for another 1 kilogram. There is doubling of maternal blood in the second trimester, where the volume of the blood of the mother goes up, it doubles, almost doubles. And this accounts for about up to 2 kilograms of that weight. Again, development of breast tissue, which is important for lactation later on after the baby is born. And then there are increase in extracellular fluids to support healthy weight. Again, there is maternal fat as well, which takes about 2 to 5 kilograms. And so because of all the parts of the body or the parts of the physiology of pregnancy that the weight goes to, it is highly recommended that women do not lose weight during pregnancy. You want to gain weight. It's important to gain weight so that you can have a healthy pregnancy and have a higher chance of a healthy outcome for the fetus as well. Okay. And so this can be optimally supported by eating not just energy-dense foods, but nutrient-dense foods that are high in protein, high in carbohydrates, but also very high in micronutrients as well. Okay. So there are risks to the mother and to the baby if too little or too much weight is gained. And for that part, I'll wait till tomorrow to talk about that. Thank you for staying with me to the end. We'll see you tomorrow.